These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akello, a smallholder farmer in a rural community in Uganda. Akello has to travel several hours to the trading center to access critical goods and services such as agro-advisory services, market information, financial services, education, even healthcare. There is only one extension worker for the whole village, which makes it hard for Akello to get the information she needs to improve her farm yields. Not to mention the difficulty in finding market for her produce. However, after Akello started using mobile digital platforms, her farming changed. In the absence of an extension worker, she calls a farmer's call center at no cost and gets all the information she needs. The call center links Akello to genuine input dealers so she can order good quality seeds and fertilizer remotely. The company or service delivers the goods right to her doorstep. At harvest, Akello gets information about where she can sell her produce at the best price. Akello gains access to new markets, and her produce is picked from her farm and delivered to the buyers on the same platform. She gets paid through mobile money for the value of the goods sold. This helps her to keep a track record of her earnings, which can be linked to her Village Loans and Savings Association group. And thanks to efforts to link savings groups to banks, Akello can access credit based on her savings history. Through mobile credit solutions, Akello is now able to get access to credit on her phone, improving other aspects of her life. She can pay school fees without traveling long distances, queuing up, and in manageable installments so that her son can stay in school. Akello also accesses nearby healthcare services from health workers supported by a digitized community health structure. However, the use of these digital solutions is not always seamless. Akello sometimes has trouble with internet network as she is deep in the rural area. Electricity isn't yet available in her village, so charging her phone is not easy. In addition, all the menus and options on the phone can be confusing for Akello. As a result, Akello sometimes can't order her inputs on time or receive orders from potential customers on time. Additionally, fees and taxes make it more expensive for her to use the service. While Akello owns a mobile phone, this might not be the case for other farmers, especially women. Using a market system development approach, UNCDF is working to ease the challenges that people like Akello face. By ensuring that there is supply and demand of digital services, UNCDF aims to achieve inclusive digital economies that support women, youth, refugees, migrants, and MSMEs to thrive. Working with mobile network operators, UNCDF is exploring ways to ensure phones are more affordable in rural areas. The digital platforms use offline mode, which saves all the information in the app until the phone reconnects to the internet and uploads the information. Solar power has increasingly become available in rural areas to address the electricity issue. UNCDF works with partners to train people like Akello to fully utilize the applications on their phones. If several of the people in Akello's village and in other rural areas could adopt these digital solutions, more businesses would invest in Akello's village. And with improved market information, they would be able to get better prices for local produce, plus improved access to social services like health and education. Of course, for local markets to thrive, there is need for the right policies and regulatory environment. Using the Inclusive Digital Economy Scorecard, UNCDF works with government to ensure that there are right priorities to support the country's digital transformation.
I'm called Nambozo Scopia. I work on Buluzwala Parish, Javazala Village. I cover 127 households. nebonanga nelometi kenze busawo kubanga nebonanga batu base bali bubi mukisinza ate ni chifo kyene kino kina kekuli ni lugudo lwesinga omutalo ale chiro lwesi balama bati bali kuyira oba kekuliko ni lidwaliro da nenalometi padali seke ni kenimi kesobose kubanga enyamba batu base bemunani bemukisinza malesi gabu makonanika kufuna mwaka guwele mwesi kwamanga corona nanika oba covid kwamanga esananika kwananika basawo bananika kugwa malesi mangata kwabanga kuza kuleta malesi gali kufuna masks kwafuna gloves ni sabunu nga kweza batu nga bezele babuli twakeza nengo uza kusaba ko mukono buli Yesu wama yena wosi uli kusaba ko mukono nga esi kyandisanire ne waja kwilinde kawuka kano chino kakeze mukisinza sesima nabikitongo ekyo kya living goods kubanga kwamanga nenanika kutamba kwingira mukisinza kiri bana base imbasobola kubalinda bulayi malesi gene gesindeta imbawa kati anika kukispendinga singi zinga linabi kugula manani malesi ni kuna chindi bude bunochi nango mwana wosalwale kubude bunochi semwene ndi ni basawo base bayipikisa ku testing. I first test on fever, then I do a MRDT to my children.
Kirungi kusindikira abasawo mambi ne batusawo twayedagala atudanjabira kwa abana baffe emisujja negiwona.
Here's how digital solutions are improving the health and education sectors in northern Uganda.
One of the things that VHTs have made very clear in the conversations we've had so far is the number of registers and the number of paper-based tools that they have to work with to complete their work. This is cumbersome, this is heavy, and already they are saying a mobile phone or a digital version of the tool would take this burden away.
A VHT will go to assess a child or go to attend to a pregnant lady, but they don't have that information that is critical to be shared with the person that they are attending to. So you find that now in this application, that information has been set there. It's laid very well. So in that it guides this person as they are doing the operations, they are guided on how to do the procedures.
Community health workers, supervisors and DHOs are trained by BRAC to use the app to track cases in their community and refer cases that can be handled at the nearest health facility.
In the phone they ask how old the person is, the child, and what sicknesses the child is having. And we ask the parents how long the child has been sick. And even it is there in the phone.
In education, digital solutions are enabling people to pay school fees more conveniently.
Ever since we started using school pay, we have had a reduction in our cost of operations, because before parents would come and pay fees in school. Then after paying the fees in school, they would after them paying fees, now we would have to start balancing books at the end of the day. Then you have to rush to the bank before 5 o'clock and have the payments. Then we had to employ one full person just in charge of writing fees which is being brought to school. Parents are now taking fees through school pay and through more agent banking. So on that area alone, we have saved about 2 million per term.
If I am using my motorbike, it takes me 3 hours serious riding from where from my home village. Serious riding, it is 3 hours. I must come all the way from that distance. And Access Bank, we have only in Lira here, the bank that we use. I come from a Leptong and I access the bank sometimes. I come late and I find bank is closed. and I have to pay the cost of my living in town, yet I've just come to pay school fees only. Then from there, the experience is that it delays me so much. But school pay is quick, and you do it just right now, and you receive the message back.
Check out our other videos to see how digital solutions are being used in other sectors.
Living Goods is set up to make sure that affordable healthcare reaches the vulnerable within the communities. And of course, with the advent of COVID-19 from last year, access was constrained where families and communities can't easily access facilities for safety-related challenges, amongst other things. The need for services by the VHTs, the community health workers, became much more even required. We made sure that every community health worker that continues to provide services has adequate access to personal protective equipment and also very clear protocols and guidelines to ensure that they are safe. These guidelines clearly stipulate what is required for social distancing, how they should be carrying out the work that they do to ensure that they continue to be safe as they provide these services. But also supporting through digital tools that they're able to assess how well they are, or if they are exposed to COVID-19, we're able to see that through the application. So there were modifications and upgrades to the application on the phone for providing services to be able to alert us on what is expected. So there was clear guidance under what circumstances they should continue providing services to communities safely. And for the community, because of the constraints that resulted from the COVID-19 and the lockdown subsequently, the Living Goods has been providing free medicines to communities. And this has significantly improved the access to affordable healthcare at the community level. We've also been able to continue the provision of family planning through the community health workers, the VHTs, who continue to visit mothers, ensuring that they have access to the much needed services for family planning as well.
Community health workers, or the VHTs as we call them, have played a big role in in accessing information to these households, to the communities, to individuals. There are certain packages that they also deliver to certain target groups in the communities, especially when we come to reproductive health, issues of family planning. So they have been trained on basic packages. They are using a phone and an app, and especially we're grateful to our partner Living Goods. They train them on using a phone, the app, that helps to drive to some kind of diagnosis and the conclusion on the medicine to give a child or those children under 5, especially in the areas of management of diarrheal disease, management of pneumonia, and the management of the malaria. Although there are some cases which are beyond their scope of handling, those ones are also referred now to the facilities. But through Living Goods and the community component, they're also contributing a lot to our enriching our data. It is summed up and it is submitted to the facilities within their catchment areas. And this data also reaches through the DHIS to the districts. It informs our planning at the districts. It has contributed towards improving those indicators, especially the dropout rates of immunization, increasing the fast acceptance of family planning, which was a bit low, and also improving on the early seeking behavior for these children, because within 24 hours for us, we encourage that if someone develops signs and symptoms like of malaria, a caregiver, a mother should take this child for treatment. But now this is a mother who is very close to the VHT. So it also improves on the cure rates, that these children can be managed as early as possible, so that when it comes to like the incidences of malaria also reduce, incidences of the diarrhea disease reduce, and also other elements that they are managing at that level.
These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akello, a smallholder farmer in a rural community in Uganda. Akello has to travel several hours to the trading center to access critical goods and services such as agro-advisory services, market information, financial services, education, even healthcare. There is only one extension worker for the whole village, which makes it hard for Akello to get the information she needs to improve her farm yields. Not to mention the difficulty in finding market for her produce. However, after Akello started using mobile digital platforms, her farming changed. In the absence of an extension worker, she calls a farmer's call center at no cost and gets all the information she needs. The call center links Akello to genuine input dealers so she can order good quality seeds and fertilizer remotely. The company or service delivers the goods right to her doorstep. At harvest, Akello gets information about where she can sell her produce at the best price. Akello gains access to new markets, and her produce is picked from her farm and delivered to the buyers on the same platform. She gets paid through mobile money for the value of the goods sold. This helps her to keep a track record of her earnings, which can be linked to her Village Loans and Savings Association group. And thanks to efforts to link savings groups to banks, Akello can access credit based on her savings history. Through mobile credit solutions, Akello is now able to get access to credit on her phone, improving other aspects of her life. She can pay school fees without traveling long distances, queuing up, and in manageable installments so that her son can stay in school. Akello also accesses nearby healthcare services from health workers supported by a digitized community health structure. However, the use of these digital solutions is not always seamless. Akello sometimes has trouble with internet network as she is deep in the rural area. Electricity isn't yet available in her village, so charging her phone is not easy. In addition, all the menus and options on the phone can be confusing for Akello. As a result, Akello sometimes can't order her inputs on time or receive orders from potential customers on time. Additionally, fees and taxes make it more expensive for her to use the service. While Akello owns a mobile phone, this might not be the case for other farmers, especially women. Using a market system development approach, UNCDF is working to ease the challenges that people like Akello face. By ensuring that there is supply and demand of digital services, UNCDF aims to achieve inclusive digital economies that support women, youth, refugees, migrants, and MSMEs to thrive. Working with mobile network operators, UNCDF is exploring ways to ensure phones are more affordable in rural areas. The digital platforms use offline mode, which saves all the information in the app until the phone reconnects to the internet and uploads the information. Solar power has increasingly become available in rural areas to address the electricity issue. UNCDF works with partners to train people like Akello to fully utilize the applications on their phones. If several of the people in Akello's village and in other rural areas could adopt these digital solutions, more businesses would invest in Akello's village. And with improved market information, they would be able to get better prices for local produce, plus improved access to social services like health and education. Of course, for local markets to thrive, there is need for the right policies and regulatory environment. Using the Inclusive Digital Economy Scorecard, UNCDF works with government to ensure that there are right priorities to support the country's digital transformation.
I'm called Nambozo Scopia. I work on Blueswala Parish, Javazala Village. I cover 127 households. Nebonanga ba nelometi kenze busawo kubanga nebonanga batu base bali bubi mukisinza ate ni chifo chene kino china kekuli ni lugudo lweswinga omutalo ale chiro lwesi balama bati bali kuyira oba kekuliko ni lidwaliro da nenalometi padali seke ni kenimi kesobose kubanga enyamba batu base bemunani bemukisinza malesi gabu makonanika kufuna mwaka guwele mwesi kwamanga corona nanika oba covid kwamanga esana nika kwananika basawo bananika kugwa malesi mangata kwabanga kuza kuleta malesi gali kufuna masks kwafuna gloves ni sabunu nga kweza batu nga bezele babule twakeza nengo za kusaba ku mukono.
Good afternoon, good morning, and good evening, everybody. Welcome to the final day of the Helena 2021 conference. We'll start by thanking the Almighty for taking us through the 3 days. And that we'll start with a word of prayer by Priscilla. Kindly go ahead and give us a word of prayer before we proceed. Thank you.
Thank you, Chair. Let's pray. Father, in the name of Jesus, we thank you very much for this day. We thank you for the gift of life. We thank you for this, Father, that you have given us. As we have the final day of the Helena 21 conference, Lord, come in our midst such that we have yet another successful day. In Jesus' name I've prayed and trusted. Amen.
Amen. Welcome once again, and thank you for staying with us since day one. We'll start by appreciating the organizers of this conference, who are the Uganda Health Informatics Association, under the stewardship of the President, Madam Carol Kamasaka. We are also going to go ahead and appreciate the local organizing committee, headed by Mr. Jonathan Impango. We can't go without thanking our partners, including the Ministry of Health, under the stewardship of Dr. Diana Atwine, the Permanent Secretary. We would also like to thank United Nations Capital Development Fund, who are one of our partners. We'll also continue to thank Makerere University School of Public Health MEDS program for supporting this conference. We want to thank Living Goods, IntelliSoft, Africa CDC for being able to support us through the 3 days and even before during the preparations. We would also want to go ahead and thank the Scientific Program Committee who are able to review and organize this conference. These include Dr. Vincent Chiberu, Professor Graham, Professor George, Dr. Francis Baba da Costa, and Madame Balira Priscilla. Would also like to go ahead and thank the presenters of this conference since day one, and all the people that have been able to make it, for sharing and making sure that this conference is a success. With that being said, we are going to go straight into the program of the day. And we'll start with the United Nations Capital Development Fund, who will be presenting the topic Sustainable Financing for Digital Health Interventions. But just before the United Nations Capital Development Fund presentation, I am going to go ahead and introduce myself. I am by the names Joan Nachiwoka. I work with HISP Uganda and also a member of the local organizing committee for this conference. Thank you very much. I'll hand it over to Julio, who is leading the UNCDF team, to go ahead and present on their topic. Thank you.
Thank you, Joanne. Hope you can hear me well. And morning, everyone. Please allow me to share my screen. Can you see my screen now?
Yes, we can.
1 second. All right, so morning everyone again. Good morning, ladies and gentlemen, and welcome to this session today at the ELINA conference. Our topic for this session is...
Julio, kindly put your presentation in presentation mode. Thank you.
Thank you. Sorry about that. Yeah, all right. So I was saying that our topic today in this session is sustainable financing for digital health intervention. Again, my name is Julio Malikane. I work for the United Nations Capital Development Fund. I'm leading and managing our digital health and education portfolio. In this session, I'm with partners, implementing partners and experts in the digital health space. We have Brian Senago from MEDIC and Peace Otage from Medical Access Uganda. So I'll start by introducing UNCDF to our audience. UNCDF, it's a United Nations agency mandated to use financial instruments such as grants, technical assistance, loans, guarantee to address key market constraints in these in key sectors, including the healthcare sector. So we use digital technology and digital model to address some of these market constraints. And today we'll have an opportunity to hear from our partners about their digitization journey into different level within the healthcare structure. So we'll hear, so last year, UNCDF entered in a partnership with BRAC and MEDIC to digitize a VHT model, a digital VHT model for government. We all know that BRAC and MEDIC has been working in that space for some time, focusing on private sector model. So we invested into, we actually provided technical assistance and grant to BRAC and MEDIC to implement a government model. So we'll hear more about that later. So again, last year we entered in another partnership with Medical Access Uganda and Signalytic to digitize stock management at lower health facility. We'll have also an opportunity to hear from Peace more in details. And lastly, this year we entered in a partnership with IDI to implement a drone project as a COVID response initiative. So with BRAC and MEDIC, we are implementing a digital model for VHT. Kindly allow me to invite my colleague Brian to present and share his journey through the digitization at this level. So my question to him is, could you please share your journey and experience in implementing a digital model using a community health information system at the community level for government? What are the challenges and what are the current and future opportunities? And to close, what aspect to consider to ensure sustainability and attract more investment into the future? Welcome, Brian. Feel free to share the screens as well. Thank you.
Thank you very much, Julio. As I get this up and running, glad to have the opportunity to share more about this work. And really at the heart of this conversation is how we have partnered and utilized the funding opportunity to really take this work into the public sector and bring it to life. We have taken a lot of lessons and experiences from private sector implementations, but it was important to understand that designing for public sector is a very different game. And having UNCDF come alongside us to do this was the perfect opportunity. VHTs provide household care, and they are the heart of that community-based care. Without supporting them, the healthcare system remains challenged, especially in aspects where we really want to understand what's going on at the household. So for me, I think the ecosystem is ripe with a lot of Ministry of Health intervention and coordination. But I really think the partnerships between BRAC and MEDIC, as an example, and UNCDF as a funder are key in supporting districts to really digitize the work of VHTs. If we're not able to do this, it's going to be very difficult for us. The kind of product we're talking about is a simple product, a product that aligns with digitizing enabled supervised VHTs. And some of the features that we're talking about are what you see on the screen here. VHTs already do this work in the non-digital form. And so what we have worked on together is to really bring the digital aspect of this work to life. Longitudinal profiles for patient-centered care, decision support for the VHTs, managing their day-to-day tasks, and then data and data use, starting right at that lowest level. And obviously, not forgetting our partnership at the Ministry of Health. And in the interest, I think it has been a big theme this week, interoperability and the health information exchange. We're also looking to see that the community tools get to that level. So the VHT remains core at the household level, and we want to make sure that that's important. But the investment helps us to work together to really understand where do the tools have the greatest impact. At the doorstep care, the VHT is empowered with a mobile device. But what we're really seeing is the entire ecosystem. And so you sort of see that supervision level kicking in at the facility or sub-county level, where you're using a device capable of showcasing the data and the dashboards well, and you're plugging into the district administration pretty well. I want to go to Julio's second question, which is what's the role of the tools and the process to improving this quality care? We didn't just come up with a tool because it was a good idea. We really wanted to plug into the priorities of the ministry. So we've worked hard to align with the community health priority number 5, that is around digital and empowering digital in a very intentional and committed way. We've worked carefully with the Division for Health Information to understand their specific priority. We're no longer building and deploying data collection tools. We're deploying care coordination tools. We want support for the VHT as if it was their day-to-day job, not a new tool to collect data. It's been important for us to work with the districts to understand how might digital support not just decision-making at the district, but also alignment and reporting. And how could we work to make sure that the data looks great, but also arrives in time? And for me, that's really the role of these digital tools and the capability that they give to us. I think there's a third question here that is very exciting. Julio has asked, what's the future of this digital model for VHTs? What can we look forward to? And what are the kind of opportunities we have? So in West Nile, it took us about 6 weeks only post-deployment to arrive at about 7,000 households registered. For every household registered, this little data set is the potential for the health system to have a record for who is in the household, their name, their number, their health condition, their status, their metrics within the context of health promotion and health service care. And this is very important. 6 weeks just for us to get to all those households. Imagine the potential that we could have for the type of data we have. But also for every VHT that we have digitized, we now have their record. And so imagine the potential for the community health worker registry and the digital tools at the community level supporting that integration. This is massive. It's massive for districts dealing with RBF. It's massive for the ministry understanding the real coverage and reach of the VHTs in the community, but also the care ratios. You know, how many households are under each and every single VHT. One of the big and exciting opportunities we have had is we have unlocked the potential for supervision. If you think about it from the health assistant, the first official level of a supervisor of a VHT, through this work, we're now able to really see and bring to light what are those supervision actions. This hasn't been possible before because our current HMIS tools, paper tools, do not provide for how to track supervision. The potential for this is so big. Supervision quality, supervision activities. We're currently in West Nile and supporting the districts to launch a connection for stock monitoring at the community level. The potential for us to see consumption of materials at the community integrated into health facility quantification. Imagine what that can do for the quality of ordering. This is the potential for the tools, and this is the future of this digital model. And this is why I believe the partnership that we have with UNCDF, with BRAC, and with all these other partners who are intentional about supporting the community, the potential we are all sitting on is so big and massive. And I would really encourage more partnerships in the tools, in the way that we're working with the districts, in our alignment with additional digital partners, as well as the Ministry of Health. Julio, I'd like to come back to you. I hope I have answered the questions.
Thank you, Brian. So I think you've answered very well. In the meantime, please share your email via the chat box to allow anyone who is interested to know more about the digital model for VHT in Uganda to reach out to you easily. This time I would like to talk about our second partnership with Medical Access Uganda and Signalytic, where we are digitizing the stock management, the digital stock management model at lower health facility. We know for sure that it has been a challenge to get visibility of the stock level and commodities at the lower health facility. This is mean the health facility number 2 and number 3. So allow me to invite Peace Orange to share her journey into digitization of this health facility level, but also by answering this question. So my question is, could you please share your digitization journey at lower health facility? What are the key challenges you face? What are the current and future opportunities? And what are the key aspects to ensure sustainability and ensure and attract more investment in the future? Welcome, Peace.
Thank you so much, Julio. I'll just share my screen. Good morning and good afternoon to members, wherever you are tuning in from. So I hope you can all see my screen. I'll take on your first question, Julio, in terms of experience in implementing the digital intervention. So as part of the Digital Innovation for Health project, Medical Access Uganda Limited, in partnership with Signalytic, a Canadian-based firm, with strategic oversight and support from our partners like the Ministry of Health, UNCDF, and implementing partners within Kiriandongo district like Baila, are looking to provide a robust, locally assembled digital stack. We call it a digital stack because it's bigger than just one solution. It sort of provides one single point of entry that can host multiple solutions. Now, the purpose of this intervention was to improve the management of essential drugs and medical supplies. Our target space was 25 lower level health centers, that's 2 and 3, within Kiriandongo district. Now, the unit itself consists of a solar panel, a tablet, a microserver, and a cell antenna. And it was designed through months of really understanding end user challenges, their requirements and workflows. We held a number of user acceptance testing and user review sessions through the months with key stakeholders like store managers at these lower level health facilities. We also engaged with health facility in charges and the district team. And from that, we learned that we really had to address all the problems that affect the supply of essential medicines, both horizontally and vertically, namely things like digital infrastructure, cost, extensibility, interoperability, having locally owned and locally supported solutions. Now, our solution has the ability to pick up signal from various service providers. This is through the cutting edge cell antennas. We are able to connect to the strongest cell tower and thereby eliminating possibilities of connectivity drops. We have so far been able to register 100% uptime at these lower level health facilities, even facilities with signal strengths as low as 2G and GPRS. We have also been able to realize 100% data sync between facilities. In terms of preliminary estimates from the data requirements for a district like Kiriandongo, where our target was 25 centers, we are looking at about samples of 4.3 GB per year, including firmware updates. This is indeed a revolution in terms of costs of internet and overall expenditure that is currently the case in a majority of our health centers. The user-facing application, which is the tablet, was designed to be workflow-oriented. One can host a number of digital apps, content, and information. It was also designed with the user, and emphasis is on simplicity, and thereby allowing the user to focus on the quality of services and not on uptime of the technology. During our training sessions, we really tried to encompass a lot of trainer of trainee approach to create a network of system champions that would offer support to less skilled staff and thereby improve overall sustainability of the system and the project. In terms of the role of the digital tools, that was the second question. I think we see by offering a reliable digital system, end users can focus on activities like stock management through things like requisition and ordering of medicines, essentially the important stuff. The role of the system that we provide is to easily capture stock data from health facility nodes and ensure accessibility and visibility of this data in real time across the value chain, both horizontally and vertically. In terms of what we think the future of digital inventory at these lower level health centers, I think that was your third question. The platform we have developed creates a locally managed integrated digital health facility. Yes, even at Health Center 213, it is possible. And with the options and possibility to extend to other variations like DSD models, it offers a cheaper, simpler, and faster approach to attaining supply chain visibility, leveraging on solar power, a sustainable energy solution, and adapted blockchain tech to provide secure data synchronization across networks of stakeholders like health facility staff, in charges, the district teams, further up to the central warehouses that distribute drugs to these health facilities, and strategic partners like the Ministry of Health. The future opportunities we see are endless. We can host any and all digital apps and content, but also connect to other 4IR technology like drones, GS1, medical devices, biometric. Essentially, the possibilities are endless. We see this as being the cornerstone of the digital revolution in lower level health facilities. By reducing operational costs, building for longevity and enabling uninterrupted digital transactions in these lower level facilities, we can not only improve health services at the lowest level, but also foster a culture of informed decision-making by upstream stakeholders through the added visibility provided. And we can subsequently attract more investment by being able to demonstrate operationalization of a sustainable low-cost digital stack, visibility and accountability across the value chain to investors and providers of health commodities. So in summary, I do believe the future is digital, and I really encourage each of us to embrace such innovations that are being taken to ensure that we have a more smart and digital ecosystem within our health sector. So I think I'll pass the torch back to Julio. I hope I effectively answered all your questions.
Thank you so much, Peace, and very good presentation. Really, I'd like to say that digital transformation in healthcare is crucial to improve the quality of service and performance at both community level and at the lower health facility level. This is the right time for investment into this space because we believe that at UNCDF, we believe that if it can work at the community or at the lowest health facility level, it can work everywhere. So we really invite other stakeholders to come and invest into this space and really try to unlock this market constraint to ensure great service in Uganda healthcare sector. So we still have 5 minutes. So in the meantime, please share your email address on the chat box to allow participants to share their questions. And for the remaining 5 minutes, we would like to welcome some few 2 or 3 maximum questions before we close this session. So any question from the participants? You can raise your hand and then we can give you the floor.
Thank you so much, Julio and team, for that very enlightening presentation and discussion. There's a question that was dropped in the chat. Brian, I would like to invite you to expound more on it, on the response, much as you had already dropped a response in the chat. Thank you.
Thank you, Joan. Infrastructure challenges are ripe, especially in the community. And in my case, or in my example, the VHTs really work at the very, very lowest level. And without investment in infrastructure, we can't solve certain things better. Some of our villages and communities are still off the grid. It's opportunity for digital interventions to think outside the box, which is why we deploy offline first. But at some point, we still need this connectivity. You'd notice that the role of our telecom companies is very limited when we're discussing the potential of technology in deployments. And now is the best time for us to really bring these gentlemen and ladies on board and say, can we have a conversation? If I have 400 VHTs in West Nile active and then on your network, could you think about whitelisting data transfer? Could you think about boosting the network strength and speeds in the region? Because this is, and it fits very well with any corporate social responsibility outcomes that they could like to tag to. But yes, infrastructure challenges are real, and it's part of the overall enabling environment, and we do want to make sure that we solve those challenges. Now is a really good time for us to think about it. I also want to use this opportunity maybe to just draw attention to standards and operability. I know it's a big theme this week. It's been a very strong conversation, but it's really, really time for us to coordinate all of these digital opportunities into that health information exchange. There's so much data that we're just losing track of utilizing because we're not yet inviting those elaborate spaces to connect together. Thank you.
Chair, if you can allow me to compliment Brian.
Kindly go ahead.
Yeah, so talking about digital infrastructure, this is actually a real issue within this market, and we know for sure that for us to cover those areas, those last mile areas, we need support, or we need investment from the telcos, and we know for sure that telcos are driven by profit because they are private sector companies. And those kind of market doesn't make business sense to them. So what can we do as the development sector to invest in those areas? So one thing that we are trying to address with the Medical Access Uganda project is really to find an innovative digital infrastructure that can work with very limited connectivity or no connectivity at all. So with our pilot in Kiriandongo, we have a digital infrastructure that is solar panel powered, and we have micro servers that can still communicate between the 25 health facility to update each other, and these facilitate the exchange of data within the same network, even when connectivity is not present in or is very limited in one of those areas. And when connectivity comes back, the system syncs in all the micro server to make sure that the most updated data is accessible to all the health facilities. So this is actually one of the options we've trying to solve the digital infrastructure. However, we need to work with private sector and startups to really think outside the box to create some of these innovative model and innovative technology to try to solve these without waiting for the telcos to come and save us. Thank you.
Thank you very much, Julio, and thanks to that team for the strides that you have so far taken and sharing your experiences. There is another question in the chat that I will request that you respond to within the chat. We are going to move on to the next item on the agenda, which is a panel, African Union Health Information Exchange Policy and Standards for Digital Health Systems, Vision and Next Steps. I am going to invite Dr. Tom to take over and lead this panel. Thank you. Over to you, Tom.
Okay, thank you. I was trying to get myself yeah, thanks. I was trying to get myself unmuted, but I couldn't. Good morning, everyone, and good afternoon, wherever you are. Yeah, thanks so much to the organizers, to the for giving us this opportunity for this panel presentation. This is going to be a joint effort that's going to be presented, led by Africa CDC and colleagues from University of Gonda in Ethiopia, who've been working closely with Africa CDC and the Africa Union to develop the standards, policy and standards for health information exchange for digital health in Africa. And again, interoperability has featured a lot in over the last 3 days, and data sharing is becoming a key thing, whether it's in clinical care, in surveillance or program monitoring or research. So the Africa CDC led this activity, and without talking too much, I'm going to introduce my colleague, Dr. Cheng. I hope she's on the line. Mercy, are you on the line? Mercy, are you on the line? Okay, if not, then I'm going to introduce other panelists. We're going to be kicked off by Mercy Cheng, who's with Africa CDC. I don't see her on the line, or if she is, I hope she can be unmuted. The other key panel member is Dr. Binyam, who I see on the line. Binyam Tilahun from University of Gonda. If you can be unmuted, please. Because Dr. Binyam in the absence of Mercy, is going to take us through a presentation that's going to form the basis of our panel discussion. So if you can unmute Dr. Minjam, please, then you can take over and give the presentation.
Okay, thank you so much, Tom, and then everyone. Nice to see you all, even though it's virtual this time. So yeah, thank you so much. I think with my name, Mercy also joined. So maybe the admin, can you unmute? I can see my name in a couple of times. So for the introduction, Mercy will be presenting. So maybe can you unmute Mercy, please?
We would like to know the name that Mercy is using to join the call.
I think she joined with my name, or
yeah, C2 Binyams.
Yeah, like there are a couple of Binyam. Can you unmute them?
Yeah. All right, thank you.
Okay, thank you so much.
Okay, thank you so much.
Thank you so much, Mercy. I'm not sure quite.
Good morning, everyone.
So, yeah, thank you.
Yeah.
So, Mercy, back to you, please. Go ahead with the introduction. Thank you.
Okay, I am called Mercy Tetu, and I am the program coordinator for event-based surveillance, and I'm also the focal point for health information exchange with the Africa CDC. It's a pleasure to be part of this this conference. So looking forward to the presentation. Am I to go straight on? Binyam?
Yep, please go ahead.
Yes,
okay,
go ahead, Mercy.
Okay, fine. That's fine. So can you allow me to share my screen? Kindly let me know if I'm good to go.
Yeah, you are good. Go ahead. We can see you.
Okay. Thank you. So I'm just going to give you a quick overview of the African Union Health Information Exchange policy and standards for digital health systems. But I'm going to focus my presentation strictly on what Africa CDC envisages, and my other colleague will take it up with the details of the document. I know I have just 10 minutes to go, so I'll be a little bit quick. So this is the outline of my presentation. Sorry, I have to minimize. So as you can see on the screen, Africa CDC envisages a safer, healthier, integrated, and prosperous Africa in which member states can efficiently and effectively prevent disease transmission, implement surveillance and detection, and always be prepared to respond effectively to public health threats and outbreaks. However, this cannot be this cannot be achieved if there is no data sharing across the different levels of health system and also across borders. So to this regard, Africa CDC led the development of health information exchange policy and standard to guide countries in the establishment of strong system, robust systems that can facilitate information exchange by the provision and recommendation of policy standards that can lead this process. So this is how we envisage, and this is the roadmap of which Africa CDC intends to follow. So this is kind of a quick background on why this document came into existence. We know that AU member states have increasingly been implementing digital health systems to improve health outcomes. However, most of these systems use technologies that are functionally suboptimal and are not interoperable. And we know that interoperability, especially around digital health solutions, provides immense opportunity to achieve the universal health coverage, the Agenda 2063 that is being led by the AU, and the Sustainable Development Goals, while also gearing towards, especially in the health domain, achieving the IHR. For those that are not versed with IHR, it's International Health Regulations. So this situation even gets worse because there is the absence of policy and standards to guide health information exchange across the continent. And also there is, given that the market is very free and liberal, every company is developing their own solutions. And this is also impeding on health information exchange, given that there are no standards to guide this. So to this regard, a health information exchange task force was constituted and to develop the AU health information exchange policy and standard. And this was done in February last year. So the approach that this task force used was reviewing scientific publications and governmental reports on health information exchange standards in Africa, also reviewing internationally known comprehensive and robust data exchange standards. And also we had, since this task force was made up of several experts drawn from different continents, leading several different initiatives on digital health systems. We also had suggestions from the task force members and also from the member states themselves. So the purpose of this policy document was to provide sets of policies, standards, and also framework to guide member states in the implementation of health information exchange for digital health systems within the continent. And the scope of this document was kind of focusing mainly on electronic data exchange and security standards to assist Africa CDC in defining and specifying a target system framework to guide Africa CDC and also member states long-term development and implementation of health systems. So the content of this document, we have three main sections: the policy, the standard, and implementation framework. And so far, this document has been validated in 2 regions. We are done with that of the Western region that took place in Senegal. And it brought together 10 member states that reviewed this document. And folks were nominated from the ICT department and also the Ministry of Health to review. And presently we are in Congo doing the second validation. And we have with us 8 member states that are also providing input into this document. And one of the major outcomes that we've had is that at the end of this validation workshop, countries are now seeing the need to establish a community of practice where they can share best practices, they can share the new advancements, development within the health information exchange space. And also this document is currently guiding the development of Africa CDC Continental Data Use Assessment Agreement. And so we have constituted a task force internally as Africa CDC. We have focal points from the different divisions. We also have identified our different data needs and that of the regs. And we've also identified incentive for data sharing, given that countries will definitely ask what is in there for us. So we have that incentive that we can use, and countries can also see how to innovate to use internally to see that lower levels share data across to them. They help this document, even though it's still at a very, it's still draft, but countries are beginning to pick it up. And an example is the Ethiopian EPHI that we're currently working with on a World Bank project. So they're also making reference to this document. Lesotho Ministry of Health, recently we're supporting them, and they're also making reference to this document. So it's actually gaining traction already. Presently, we have developed a kind of an event management system that we envisage for it to serve as an interactive data sharing platform. And this event management system has been developed on the THI's tool, and we purposefully chose that tool because we felt like 95% of member states are currently using that for routine reporting. And so this platform has been developed, and we are planning to use this to, using the HIE guiding document to serve as an interactive mechanism whereby countries can now share information and also get an improved version of the data that has been shared across with Africa CDC. And it is also very interesting to know that Africa CDC is establishing a very, very robust data center. The specifications for this data center has been developed, and it has been advertised. So this is a call for all the private institutions and firms that are currently on this conference to make to optimal use of that opportunity and tender their bids to support us in the development of the center. So our next steps are kind of very straightforward. We want to serve as leaders on the continent to provide regulation and standardization, especially on policies, interoperability, exchange, and sharing. We also want to provide capacity building for member states. We want to start after the validation process is complete to conduct a kind of situational analysis to know where countries are, especially around health information exchange. And this we are doing because we know that the continent is not a homogeneous body. Different countries are at different level. And we're providing training and mentorship, a joint platform for sharing lessons learned, and that's why we are already constituting the community of practice. We also want to promote data availability, access, and use through high-level advocacy sessions and also regional strategic meetings. We'll be having also an inaugural meeting on this aspect come next year. We also are looking forward to collaboration and partnership, looking at the different resources that are available for the continent and guiding partners, guiding sponsors and funders on how to allocate resources based on our assessment that we are about to conduct. So this is our end target. This is how it looks like. We have developed the document. We have to advocate for countries to adopt. We have developed or in the process of finalizing the data sharing agreement. And at the end of the day, we'll be using our event management system, which we are currently initially mentioned that's going to serve as an interactive data analytic platform to support countries to share data across borders. And this is not only going to be across borders, but also we want to build in-country capacity so that countries can start having some sort of data integration across the different levels and also data sharing across different sectors. I thank you so much for listening, and I will throw this back to my other colleague who will be advancing with the next bit of the presentation. Thank you. So my next colleague that will be presenting is Stefan. He'll continue with the details of the document, the policy, and the standard section. So over to you, Stefan.
Dr. Tasfam, please go ahead. Arvin, please unmute the presenter who is raising his hand. Thank you.
Good morning, good afternoon, everyone. My name is Tasfahun, and I'm from the University of Gondar. I will be providing an overview on the three main sections of the AUHI policy and standard document, which is the policy section, the standard section, and the implementation framework. Let me just share my slide. Yeah, so the first section, which is the policy section, has six main topics: the governance, the continental data exchange architecture, the data reporting, data ownership and use agreements, and open data, and the data privacy and security. So the governance section includes set of behaviors, policies, standards to establish and oversight the AUHI policy and standard. And the governance framework aims to serve as guiding principles of the health information exchange. And it has several principles. And that of the legal framework aims to ensure member states comply with available national and international laws and regulations. And then the governance, regarding the governance body, the Africa CDC it will be the governing body for the AUHI policy and standard document. And the Africa CDC shall establish the community of practice, which is representative from AU member states, to oversee the AUHI policy and standards. And the community of practice also shall establish the technical working group, which is more of oversighting the technical aspects of the HI policy and standard. It could be like implement the platform selection and approval, and it provides recommendation to the community of practice for decision. And this is a diagrammatic representation of the continental data exchange architecture. And the figure shows the information flow starting from a facility level health information system to Africa CDC, WHO, and the regional bodies such as RSCC and RAC. And the number 1 through 4 identifies information flows, and the flows number 1 and 2 shall be facilitated by the member states. And in the table, the from column indicates the initiator of the data exchange flow. And once the flow is initiated, the actual data exchange will be bidirectional. And each flow includes one or more processes, as you can see in the table. And for each process listed, there is a corresponding data content and security. The type of data that can be reported could be mortality, clinical data, laboratory results, notifiable disease surveillance, and others. The other section is section B, which is the standard section, and it includes several standards, data exchange standard, which include the system standard and communication protocol, which includes sensor communications, transport layer security, and messaging standard, which includes HL7 for public health messaging, and DICOM for medical image exchange. And we have also ADX to exchange aggregated and metadata. And we have also included the vocabulary standards, including ICD-10 for coding diseases, and we have SNOMED for coding terms of clinical findings, symptoms, diagnosis, procedures, and pharmaceuticals. And we have also other standard, including the integration profile, which is a standard for mapping local identifiers and sharing patient profiles. And regarding privacy and security standards, we have external assessment audit, where we recommend the Africa CDC for creation and maintenance of audits. And we have also risk management. We recommend that the Africa CDC shall use Bayesian network analysis and Octave. And we have security standards such as certificates, hashing algorithms, and others. And the other one is the Common Foundation Standard. And we recommend standard management for Africa CDC to establish an ongoing workshop group to continuously review all the standards. And we have also messaging exchange standards test support for Africa CDC to establish a messaging testing environment to validate messaging implementation. And we have also forwarded protocol and service for interoperability. The third section is the HI implementation framework. In this HI implementation framework, we have highlighted the roles and the responsibility of the Africa CDC, the AU member states, and the National Ministry of Health partners, stakeholders and service providers, we have highlighted their roles and the responsibility. And as implementation use case, we have included detailed use case for COVID and HIV, and we have also highlighted the cloud and shared services for it. For instance, this figure highlights the implementation details to realize the COVID and HIV use cases. And the use case include the Africa CDC and or RSCC internal services, the Africa CDC shared services, as well as the AU member internal services. And all these services can be supported with the Africa CDC cloud services. And we have also included the capacity building activities, which include acquisition and procurement of a cloud platform, design and development of shared registries. And we have also suggested to develop a curriculum. It could be short or long-term curriculum on public health informatics fellowship program, so that competent health informatics professionals can be produced to successfully implement the AUHI policy and standards. And we also forwarded an investment framework, and we have suggested a whole government approach, cooperative investment approach, and investment case framework based on the figure given here. And we have also highlighted some monitoring and evaluation activities, which include HI maturity assessment among member states. And we have also forwarded digital health system infrastructure for health information exchange and digital health system adoption, and also its operation. So it's very difficult to present the whole document within 10 or 15 minutes. But in short, this is the AUHI policy standards and the implementation framework. Thank you. Back to you, Binia.
Hello, Binyam. Are you able to unmute yourself?
Hi, okay, thank you so much, Kisfine, for that presentation. Can you hear me okay?
Yes, we
can.
Yes,
we can hear you.
Thank you so much. Okay, so thank you so much, Dr. Kisfine, for that wonderful presentation. So we are going to open this up for questions and discussions on both presentations. So is this question coming to this presentation? Are the plans for exchange of patient level data or aggregate data across countries? From Martin Were, would you want to let me know if I didn't get the question right? So I'm seeing two questions from Martin Were. There are various definitions of validation. Does validation here mean review and provided feedback? That is his first question. The second question is, are the plans for exchange of patient level data or aggregate data across countries? So maybe let me take the first question, and then I would defer to Binyam if he has any additional remarks to make. So regarding your first question, the validation actually means review and provide feedback. and ensuring that this, if there was any contradictory statement in the document that does not align with your country policy, then highlight it, so that we know that all this document actually aligns with the country level policies and it's not contradictory to any existing policy on the continent. So that is the first. Then the second is there anything in the document that you think is missing that you think should be added from the technical perspective? So we have this this representative that are making inputs, and they're looking at the document, and if the recommendations that were set in for on the standard section is not comprehensive enough and think there are other recommendations that need to be added, they are free to make that input. And if on the policy they feel like it's not comprehensive as well, they are free to add if need be. So those are the things that we are flagging and also incorporating in the document as we move around doing conducting the validation. Again, we understand that a continental document cannot be a one-size-fits-all approach where countries can just pick and then run with. They need to adopt, they need to customize to their local context to be able to use it effectively. But this is a very generic document that provides those sets of policies and standards that we feel as the task force is relevant for effective health information exchange. The second question is, are the plans for exchange of patient-level data or aggregate data across countries? I know this is now referring to Africa CDC because we are pushing for data sharing within countries and across borders. So, patient-level data, it depends on what you're referring to, because you can still encode patient-level data and ensure that we don't have any personal identification information, and also ensure that there is some level of respect for privacy, and that is one of the very key issues that we raised in the HIE policy document. So all of these have been captured, but as Africa CDC, we are not really interested in point of care data. But depending on what the situation is, if it's an outbreak, then maybe we want to get more information. But like I said before, there is a framework for a data use agreement, and that framework has been clearly outlined in the health information exchange document that we developed. So countries would want to work with Africa CDC to pick out those different data sets, those different indicators that they feel comfortable sharing with Africa CDC. But again, Africa CDC is not really interested in very granular information, point of care data and stuff like that, or clinical data, but more of aggregate data. But when it comes to outbreaks, then we want to get more granular information as to the details. But again, this can only be done through a data use agreement. Binyam or Tesafon, feel free to add.
Can the organizer unmute the panelists, please? You could unmute all users with the name Binyam Talal.
Yeah, great. Thank you so much. Just to add one point, as Mercy described it, like most of the data will be like the data we are going to exchange. More of it will be unaggregated data. But the idea is even an individual data, like if it's going to be identified, and then if we can analyze for some kind of scenarios, that's also the other approach, which was being discussed by the task force. So, like in the presentations, as you saw, this document was developed by the task force, around 27 task force from all over Africa. So that was the recommendation of those experts, those leading experts from the continent. But like moving forward, now we have the validation in West Africa. Currently, Mercy has found everyone is in Central Africa doing the validation. But if there are any issues which needs to be changed on the document at the country level, those will be managed during the validation process based on the member state feedbacks. That's the point I want to add. Back to you, Mercy.
Hi, Binyam and Mercy. Can I just throw in one more point?
Yeah, go ahead, please.
Yeah, so this is Tom Oluoch. Yeah, so I was also a member of that task force, so pretty familiar with the proceedings and the document. On that same question about individual person level data versus aggregate, there's issues around cross-border surveillance, which if you're looking at case-based reporting, like in the case of like an outbreak like COVID, where you really need to exchange individual patient level information to be able to track cross-border movements and stuff like that, then that's where issues, and I think Mercy alluded to it and Binyam also highlighted it, the issue around the identified individual patient level data. So much as the document is focused on exchange of aggregate data, there's also scenarios where, like cross-border surveillance, for example, which may require sharing of individual patient level information. And I guess within the document, when you look at the standards that are adopted, including privacy and security policies, they do provide for those scenarios as well. So I just wanted to add that. Thank you.
Thank you,
Thank you so
Tom
much,
and
Tom.
Binyam. Okay, thank you, Tom and Binyam, for that very, very insightful compliment to the discussion. So I'm seeing a question from Stephen, if I got it right. So, sorry. Okay, let me take Olivia's question, then I'll go to Stephen next. There are some efforts of country health information exchange using the Open Health Information Exchange Implementation Framework. How does the AU coordinate with these other implementation framework? So I think this is a very, very good question, and I'll defer to any of the task force members to chip in should they want to start.
Stephen was the chairperson for standards. Maybe Stephen, can you come in and then say some words? I can see your text you're writing on that too.
Thanks, Binyam. Good morning, everyone. Thanks a lot, Mercy. Yeah, so I think to Oliver's question, and I attempted to answer that on the text. During the development of the document, we looked at all this work that's going on across the world, including OpenHI as a reference implementation. And there's a lot of reference to OpenHI, obviously, because it's probably one of the leading health information exchange frameworks that has been implemented and maybe really built on best practices and standards. So you'll find a lot of reference to that. But I think as Binyam's mentioned, and also Mercy mentioned as well, there's a lot of interaction with AU member states to really understand what they're doing and ensure that this document, because it requires to be adapted to country level and implemented, that it actually builds on top of the successes of each country. So there's a lot of collaboration going on. And I think Binyam has explained that there's already been work going on in West Africa, in Central Africa, and there are plans to go to other parts of the continent. Thank you.
Thank you, Steve.
Okay, thank you so much, Stephen, for that answer, for that response. So there's a question from Derije, and the question is, the aggregate data seems more of surveillance. Does it also cover clinical data?
May I respond on this?
Okay, that's fine, go on.
Yeah, in the document, we have clearly highlighted that there are three types of exchange. One is aggregate data. It could be some patient-level clinical data, and also kind of hybrid data, both the aggregate and the clinical data. So the type of exchange could be either clinical or aggregate or combination of hybrid and clinical data. Yeah. Thank you. Back to you.
Thank you so much, Tesfon. And we take the next question from Elizabeth. In health information exchange, there is elaborative knowledge about the integration. I would like to understand its migration approach. Elizabeth, would you want to expand further? Should we unmute you to explain this further? Can you unmute, host, can you please unmute Elizabeth if she's willing to talk out so that we understand the question better?
Elizabeth, you're unmuted. Kindly go ahead and expound on your question. Thank you.
Looks Elizabeth is in class, so she's unable to speak. She just write on the text.
Okay, kindly mute her as we move. I don't know, did any of the chairs understand the question? That the HIE, there is elaborative knowledge about the integration. I would like to understand its migration approach.
Yeah, to be honest, I mean, it's not, the question is not very clear to me because I didn't know whether it was referring to migration of data in country, or it's just not, it's not very clear to me. Sorry.
Yeah, probably if I can comment on my understanding, I think the question is like on the idea of how we can migrate data to, as Taswan was mentioning, having a server at the Africa CDC. So if the question is that way, I think the idea is like to have a backup or to have a second line server in Africa CDC so that we can have de-identified data from the member states, so that de-identified data can be analyzed, can be visualized, and then can be used for decision making at the continent level. But there will not be a migration of data from member states to Africa CDC either. So that's what I understand from the integration as well as migration of data at the Africa CDC level.
Okay, thank you so much, Binyam. I just hope, Elizabeth, you're comfortable with the response. So maybe we move on to the next. Okay, sorry, I see it's Manish that is making a comment. Yeah, go ahead, please.
Yeah, actually, yeah, I was going to make exactly the same comment that Manish has pointed out. So again, just to say that I chaired the policy group of the document development. And I think what Manish says is very important, because as we talk about continental health information exchange, it's very important that national policies and national standards are well established, so that if you're talking about exchanging and data, and if I just go back to the presentation that Dr. Tesfahun made, he talked about the data exchange architecture and the movement of data from the health facilities to the subnational level, to the national level, and then all the way up to the continental or Africa CDC level. So even before we think about exchanging data at the continental level, I think what Manish is trying to say, just remind us, is that it's important that we set our national standards and national policies to create the right environment for secure and well-protected health information exchange. So those policies start in country before we can even scale it up to the national and continental level. So yeah, I just wanted to emphasize that. And also just to remind us that we only have 5 minutes left. So I know there are many questions still coming. So Mercy, I want to hand it over back to you, but I just remind all of us that we have like 4 minutes to go. Thanks.
Okay, thank you so much, Tom. Okay, I'm still trying to see if there are any more questions. Yeah.
Yeah, probably
okay.
To add on this.
Okay, go ahead.
Yeah, I mean, in the document, there are several recommendations to AU member states. For instance, a mechanism of ensuring data confidentiality, integrity, and availability. The mechanisms are recommended to AU member states, in addition to having national policies and standards. And it's good also to validate the alignment of the AUHI policy and standards with the national available policies and standards. And of course, we are validating this through the workshop, but further ensuring the alignment of the AUHI policy and standard with the national available laws and regulations should be met. Yeah, back to you, Mercy.
Thank you so much, Binyam. So let us take the two last questions and comments. So is there a plan to demonstrate the practice between member states with strong HIE and Africa CDC for other countries to benchmark from? Let me start by taking up this one, and then maybe one of the task force members can also weigh in. So for as Africa CDC, one of the very strong components that we want to incorporate in any strategy that we want to advance on the continent is the issue around sharing of best practices. And that is why we are conducting this assessment to understand where countries are, see those that are well advanced, and see those that need some level of support to be able to pull them up to the other, to the next level. And this community of practice that we also are establishing within the different regions will serve as a platform whereby countries can share some of the very outstanding progress, or that they have achieved, and others can learn from. So this community of practice goes beyond just talking about HIE, but also bringing on board some of the technological advancements, some of the policies that are working, some of the lessons learned in the process of establishing and implementing the HIE. So I think that's a very good question, and as Africa CDC, we are looking forward to that. I hope all the member states within here will also be part of it, and even the private sector will look at incorporating the private sector as well. I see I have just 35 seconds to go. So without much ado, I don't know if there was anyone with the last word before I hand it over back to the chair of the conference.
Yeah, thank you so much everyone for joining, and then we are looking forward. If you have any questions, please feel free to email us. I will be happy to respond and then to work together on this for the continent. Yeah, thank you so much.
Yeah, I am dropping my email on the chat so that if you have any questions regarding the Africa CDC Health Information Exchange Program, you can as well reach out to us, and we will be very happy to respond to them or link you up to the responsible task force member that you would want to reach out to. Thank you again, and bye-bye.
Thank you.
Thank you.
Thank you very much, Africa CDC, for that very insightful discussion on health information exchange. We are going to have a short break for 5 minutes, after which we shall go into breakout sessions. Thank you. For that very insightful discussion on health information exchange.
These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akelo, a smallholder farmer in a rural community in Uganda. Akelo has to travel several hours to the trading center to access critical goods and services such as agro-advisory services, market information, financial services, education, even healthcare. There is only one extension worker for the whole village, which makes it hard for Akelo to get the information she needs to improve her farm yields. In Uganda, not to mention the difficulty in finding a market for her produce. However, after Akelo started using mobile digital platforms, her farming changed. In the absence of an extension worker, she calls a farmer's call center at no cost and gets all the information she needs. The call center links Akello to genuine input dealers so she can order good quality seeds and fertilizer remotely. The company or service delivers the goods right to her doorstep. At Harvest, Akello gets information about where she can sell her farming changed. In the absence of an extension worker, she calls a farmer's call for her produce at the best price. Akello gains access to new markets and links Akello to genuine input dealers so she can order good quality seeds and fertilizer remotely. The company or service delivers the goods right to her doorstep. At Harvest, Akello gets information about where she can sell her farming. These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akello, a smallholder farmer in a rural community in she gets paid through mobile money for the value of the goods sold. This helps her to keep a track record of her earnings, which can be linked to her village loans and savings. She gets paid through mobile money for the value.
Welcome back from that break. We are going to go to breakout rooms. Breakout room A is going to have leveraging technology to support Helena Education Working Group activities. That will be led by Noah Jaffa Kasiti. And in breakout room B, we shall have integrating telemedicine in routine care for hypertensive and diabetic patients, early learnings from Rocket Health Services in Uganda, led by Joy Banonia. The rooms are open. Each is going to have 15 minutes. Kindly join a room of your choice. Thank you. Members, thank you very much, and welcome back from that that very engaging discussion that was in breakout room A. We are going to return to breakout rooms again, where we're going to have in breakout room A an LMIC first implementation for agile development of process-centric and guideline-driven point of care EMR systems by Christian and colleagues. And in breakout room B, we shall have revisiting health information exchange in low resource settings, modes of health record transmission. Oliver will be leading this discussion. Feel free to join a room of your choice, and I will return after exactly 15 minutes. Thank you. You're welcome back from the breakout rooms. We are still going to go back for another round of breakout rooms, where in breakout room A, we'll be discussing institutionalizing state health workforce registry for improved human resources for health efficiency, a case of Oyo State, Nigeria. And in breakout room B, we'll be discussing the development of national health client registry within our health sector as a step forward to enhancing continuity of care and experience from Tanzania. You're encouraged to join a breakout room of your choice to discuss these very pertinent topics. Thank you very much. Please join the breakout room of your choice. Welcome back from those very interesting sessions. We are still going to go back to our breakout rooms, and this time round, we are going to have adapting self-assessment from the private sector to build the capacity of health supply chain actors in the public sector. Lessons from implementation in Uganda, led by Bridget Chobutunji. And in breakout room B, we are going to have readiness model for sustaining in strategic information for health in Kenya. Lessons learned from implementation in Nakuru and Kakamega counties. And this is going to be led by Joyce Nyaboga. Kindly join a room of your choice to join these very interesting discussions before we come back and have the second last session. Thank you very much. Colleagues, once again, you're reminded to join the breakout sessions. Kindly please join the session of your choice such that you don't miss out on these very, very good discussions. In breakout room A, we have adapting self-assessment from the private sector to build the capacity of health supply chain actors in the public sector. Lessons from implementation in Uganda. And in breakout room B, we have a readiness model for sustaining in strategic information for health in Kenya. Lessons learned from implementation in Nakuru and Kakamega counties. Kindly join a room of your choice for the next 13 minutes. It's now 13. Thank you. Welcome back again from the discussions that we had in the various rooms. We are going to remain in the main room because we are missing the presenters that were supposed to be in breakout session B. So let's have the presenters of University of Nairobi Mobile Application RADA take over. That is Lisbeth, Walter, and Jen. Thank you. In case anyone on the team that is supposed to be in breakout room B, the French paper is around, kindly let us know. Otherwise, let us remain here and get the presentation from University of Nairobi. Again, it's going to be 15 minutes. Thank you, Lisbeth. We can see your presentation, but kindly put it in presentation mode. Thank you.
Good afternoon, team. Thank you so much for this opportunity. My name is Lisbeth Kageni. I'm representing the RADA team. RADA is a mobile application that has been supported by UNESCO, Sexual and Reproductive Health, and the University of Nairobi. I'm not able to move my slides. Okay. And we are saying that college is an experience that allows young people to explore, try new things, and make own decisions on a larger scale. But on the other hand, it is a time in their lives that can also be very expensive, a very expensive investment, if not well managed. So a mobile application is called RADA because the students gave it this name. RADA is a slang word that is commonly used by young people, meaning beware or be alert. And this is how it appears on the mobile application. When you open your Android phone or the Apple phone, this is how it appears. And the reason why we decided to do this to support students, it was an initiative of the students. It's because of the data that was emerging or has emerged among the young people who make 18 million of our total population, that is 16.7%. And we're looking at the ages of 15 to 24, who are mainly in the tertiary institutions. And we are saying that percent of new infections globally occur among these populations. And in Kenya, the HIV prevalence is 6.6%, and 1.6 million people are living with HIV and AIDS. So we have 29% of all new infections occurring among adolescents and young people. Then we are also saying that gender-based violence is in institutional settings is an area of concern today. And we need to have equal access to both education for both boys and girls. So sexual and reproductive health knowledge is vital in growth and development of this population. Many of who don't have access to this information. So the University of Nairobi face many challenges. The students, in case of new HIV treatment, non-adherence, unintended pregnancies, and also substance abuse. And we are also seeing that the future is at risk because of mental health issues, sexual and gender-based violence, cases of abortion, substance abuse, STIs, including HIV and AIDS. And also we have anxiety because of lack of finances and insecurity. So the problem largely is due to lack of appropriate infrastructure and student-friendly manner. The students chose to use a mobile application because they were saying 90% of our students possess mobile phones according to a study that was done. And they were saying they want to get this information from the comfort of their areas, whether they are in the hostels, in the classrooms, or even in the compound doing other extracurricular activities. They want to access this information with ease. So initially the application was designed on Android form. After some time, the students said they needed it on the Apple phones. So this is how the application appears. For us to know that the University of Nairobi students are the ones accessing this information, they have to log in and enter a registration using their college registration numbers. And once you log in, these are screenshots we have taken from the mobile application. You get information on various health areas that we are going to see. You get counseling services that is virtual. With the students engage in forums, then there are notifications in case we have anything that we want students to know within the university. We have an help forum and then the mentorship forum. So when you open, you click on one of these, like when you click on information, you'll get so many, you'll get the news and announcements, you'll get the alcohol and drugs abuse, you'll get several icons showing you where, in case you want to navigate, they will direct where you want to navigate. And then when you click on information, for example, you want to get information on sexual and reproductive health, we have aligned, the students talked about getting informed on various relationships that they can have in universities. All the information on sexual and reproductive health is put there in their own way so that they can find fun when reading it. We have information on gender-based violence. We are also trying to look at images that demonstrate various forms of violence. And the information was so simply put because the students didn't want to labor looking at the content and reading like they are going to do exams. So the news article, we decided to major mainly on COVID-19 cases. And this is because we wanted also to sensitize the students on issues of COVID-19 and to make sure that they obey the protocols of COVID-19 and they get informed on it. But news, according to how they come in Nairobi, in the University of Nairobi, that's how we put them on the news article. So when we come to the University of Nairobi, sometimes we want, especially the new students, to locate the facilities. We want to show them where the service providers are. So there is a map on the application. We also have them engaging on virtual counseling services in case someone has an issue and they want to communicate. You can chat or you can call. But we also, through the application, we rate the counselors. Sorry for my background. We rate the counselor so that the students are able to see which counselor they want to access, to get information from. Now, the student forums, these ones, they create them according to the need. So they might want to be discussing issues on management. They might want to be discussing issues on campus trends. The other day we had activities around students and what they would want to do in terms of fun and games. So they create forums on the application. And we have also seen that some students have reported that financial issues are a major source of anxiety, mental health, and depression. So we want to help them also look at how they can do their side hustles and promote them using the application. So mental health is a serious issue. That's why we highlighted it here. Students have complained that they are suffering from anxiety, from depression. And in case somebody wants to talk like to a student, they just come there. How did you manage that issue? They talk to each other and share ideas. If there are any activities, they also share on the application. So again, we are looking at the University of Nairobi, we have a mentorship program, and this one engages both staff and the peer mentors. Sometimes a successful student might want to hold the hand of another student who is not doing well career-wise, another student who is not able to hustle or something like that, and then they have a forum that they can engage and share ideas. So this is how you request for mentorship. For you to be identified as a University of Nairobi student, you must get the registration numbers, what is a year of study, so that we can know which mentor to pair you with. And then when the mentor is approved, then you go ahead and continue now during your mentoring. Yes, so again, we have the other services listed down in case you are violated. They are justice services. In case you want issues of academic matters, you just click on the application and you are sorted. Then in case you are looking at accommodation, especially for new students, we still, through the application, you can be guided. So we still have on the application, the area where we have contacts, especially for our numbers that are toll free. For NACADA, we have worked very closely with them in case there is someone who is in need of getting help on substance abuse. And we also have a bot here in case a student is not willing to read, they can type and talk to the bot, or they can engage with the bot. Yes, so that is the application. And then this application was launched in June 2019. We attended the Botswana conference. We also attended the ICASA conference in Rwanda, and also the Switchton conference in Istanbul. Those are our students who are representing the team. So dissemination has been done in several universities. We went to Kenyatta, Southeastern Kenya, Pwani, and Masinde Muliro. Then it was updated because of the feedback we got from students. And now we are supporting 7 more universities to adopt RADA, thanks to UNESCO. We are hoping also to bring in more stakeholders for technical support and publicity. So currently we are engaging with APHRC so that we can see how we are going to do the promotion and the communication strategy to bring the application to be downloaded by a great number of students at the University of Nairobi and also on the other universities. So what is the future of RADA? So we are rolling out, as I've said, to all other University of Nairobi students. Currently we have 10 campuses. We want to make sure that all the campuses are using the application. We are also scaling up to more universities, public and private. We are providing students experiences, and we also are looking for partner support. So these are some of the students who are confessing that they find it easy to spread awareness using the application. They find it good because it relates with young people, and they can reach every young person regardless of gender, age, and race. And they're also encouraging young people to use it for information on contraception, pregnancy care, and STIs, and GBV also. So they are saying that the colleagues are now able to seek guidance at the comfort of their rooms because of the application. This is the team that was working on RADA. Some students were taking photos with the Pwani University students when they visited to disseminate. And they also had the opportunity to engage our DVC Academic Affairs by then with Professor Julius to show him how the application was really working. So the management has really supported this effort for the students and is really encouraging all the other young people who are coming in the university to benefit on the same. Yes, I stopped there. in case of any other question I can be asked.
And thank you very much, Lisbeth, for that interesting application and presentation that you have just made. We are going to invite some questions and comments on Lisbeth's presentation. If you have any comments or questions, kindly drop them in the chat or simply put up your hand. If we don't have those, we are supposed to go for a lunch break. However, we wanted to find out from the panelists for the next panel, which is titled Landscape Assessment and PEPFAR Technical Enhancement Designed for Supporting COVID-19 Case-Based Surveillance and Response, if we can move this forward and have a late lunch such that we close and instead of first having the lunch break. Steve, is that okay with the rest of the panelists?
I don't know if the other panelists are here. I'm actually just a co-author, but I'm not on the panel. Let me see. I mean, I think I'd seen Muzna. I don't know if Muzna is on the call.
One of the panelists is not there.
Do you see any?
Manish?
Yeah, okay. Manish maybe can advise.
So thank you, Steven. So Muzna mentioned Daniel, who is one of the panelists, is not here. Otherwise, everyone else is here. I don't know, Daniel, if you're joined by any other name or someone should just post in the chat so that we know. Muzna, it seems like Daniel is still not here. Yeah, Steven, it seems like Daniel is not currently. Yeah, I don't see him. I don't know if Chris, no.
Yeah, Muzna is advising that we just keep to the scheduled plan. So it's possible that Daniel was planning to join at the scheduled time.
Yeah.
All right, that has been noted. Let's go for a lunch break and we'll be back at exactly 2. We'll be back at exactly 2 East African time. That's in about 40 minutes time. Thank you.
Thank you.
Good morning, good afternoon, and good evening once again. Welcome back to the last session of the Helena 2021 conference, which is going to be a panel on landscape assessment and paper technical enhancement design for supporting COVID-19 case-based surveillance and response. I'm going to invite Manish to take over and lead us through this panel.
Thank you. So I'll request to unmute my colleagues, Muzna, Veronica, and Daniel. Muzna will be the moderator for this session.
Great. So mic check. Can someone confirm that you can hear me? Hello?
Yes,
Manish, can you hear me?
you loud
Okay,
and
great.
clear.
Okay, great. So greetings, everyone. Thanks for staying with us through the closing of the conference. I know some of you went for lunch. Some of us are getting ready for breakfast. Hope we'll have breakfast soon. So the purpose of our panel is to share the CARES Act funded project that we briefly talked about yesterday. And I'll be just reminding everyone briefly about it later, and then we'll talk more in detail. We'll talk about the initial findings. We'll talk about the assessment we've done, the initial finding and lessons learned to strengthen the country PEPFAR health information systems to support the COVID-19 response in the selected countries. Let me introduce the panelists, and then I'll begin my presentation. So first, it's going to be my presentation. I'm a medical officer at the U.S. Centers for Disease Control and Prevention. I have public health experience, including assessing, setting up, and leading domestic and international public health informatics initiatives. I have assisted CDC in several emergency responses, starting from H1N1 2009 onwards to Ebola, Zika, polio, COVID. For the CDC's COVID response over 2020, I provided remote clinical consultation. In 2021, early on, I led the initiation and early work on the CARES Act project. And currently I'm deployed as a unit co-lead, and in a couple of weeks will be unit lead for the hospital data analytics unit, which oversees the CDC COVID-19 data tracker updates. And then representing PATH Consortium, we have Dr. Manish Kumar, who has over 20 years of experience working in strengthening global health systems. He's a PI for the Global Health Informatics and several other projects, including the CARES project for UNC, and his work involves HIV, TB, malaria, and maternal child health. From UCSF, who's another implementing partner, Veronica Muti, will be representing. She holds a master's degree in public health. She has supported implementation of patient monitoring management systems with different organizations, including US government, EU, and Gates Foundation supported projects. Her current role in this project that we'll talk about today is to support requirements gathering and documentation for OpenMRS reference implementation, HIV reference implementation. And our third panelist today is Daniel Futterman, who's representing GEMBI as a senior technical program manager. And GEMBI is our third implementing partner. I know Daniel has been with GEMBI for several years and brings a lot of experience in OpenHIM, Instant OpenHIE, along with the leading role in various communities of practice such as OpenHIE. So with that, if someone can get on to our slides we're still seeing the Helena Virtual Annual Scientific Conference logo and everything.
You can go ahead and share from your end. You have the rights to.
Okay, great. Share screen. Let me bring it up first. Sorry, I was used to from yesterday that somebody else was that is interesting. Why is it not picking up my? Are you seeing? Not sure what you're seeing at this point. The landscape assessment, the first slide.
Yes, please.
Okay, great. So that was our total panel title. Let me move on. So my section is going to be specifically about the project, the background of the project, the just the usual CDC disclaimer and a project disclaimer. The presentation articulates our understanding about the related domains based on rapid desk review, which has several limitations. And so we're just starting CDC country engagement. Some of this might get corrected later on. So I'll go through the background of the project strategies, roadmap, something about the assessment, very briefly about the design considerations, and then the implementing partners will describe their work, and then Manish will come back and talk a little bit more about the design principles that we've followed. This is a repeat slide for those who have seen our yesterday's presentation, but for those who were not able to join that presentation, just a little background of the premise of why this project was started. It was all about, if you all remember, when COVID-19 started, we realized PCR testing was the gold standard test. In fact, at that time, that was the only test available. There was no rapid test available early on. That was last year, February, March, and it was realized that PEPFAR countries already have PCR machines available through the PEPFAR labs, and so those were leveraged with all approvals, leadership approvals. Those were leveraged, and also CDC was providing support for dashboards through our global health security agenda. So from that premise, we the DGHT, which is a global health and TB division inside Center for Global Health, proposed a project to get CARES Act funding to prevent, prepare for, and respond to COVID-19 internationally. The project was approved and the funding was started, implementing partners started working on it from April of this year. The goal of our project is to support the national COVID pandemic response from going forward. I'm just going to call it the pandemic instead of the whole word, response to enhance surveillance built on PEPFAR information systems. And again, for those who have seen this yesterday, it's a repeat for others. The strategy is to leverage PEPFAR's existing digital health investment through the technical assistance platform mechanism, something again you've heard of in several of the conversations, several workshops, and you've heard about the TAP strategy and the work that we're doing. The objectives for our specific project are to rapidly initiate some projects based on the 3 core technical areas, which, I'm sorry, you should be able to see my pointer now. So the three core technical areas: data integration strategies and implementation, overall health information system support, which PATH is leading, DICE is the part that GEMBI is leading, and which UCSF is leading is the OpenMRS HIV reference implementation. At the same time, some of their work is overlapping where there is for smooth handoff from one to the other. And our CARES Act funded project, the one we're closing out today's conference with, is it overlays all of the work that the 3 partners were already doing for about a year. Our countries are listed here, and the partners responsible for each country are listed here in the table. The orange highlighted ones of the countries that we are going to have initial focus on for technical development, though a landscape assessment and initial conversations have been done for all of the countries that are listed here. So a little bit more information about the 3 technical areas, which are the TAP core technical areas, ORI, which we lovingly call these ORI, DICE, and OHIS, but their details are the OpenMRS HIV reference implementation, data integration strategies, and the overall health information system support, which is the cross-cutting, which provides policies and governance guidelines, and also analytic and visualization support. Going back to the ORI, the work we are doing for this is COVID-19 OpenMRS package to enable integrated clinical care management in HIV/TB patient for TB patients. DICE, the core thing is health information exchange to enable interoperability among the different facilities and the national systems. For example, lab systems, LIS, DHIS2. And OHIS, other than the policies and governance, also the key focus is the analytic and visualization support. We're not developing new policies and governance because that's the countries have already developed theirs for the pandemic, but we're leveraging the TAP policies and governance documentation. So I want to tie it all to the TAP strategy. You've heard a lot about different aspects of it, in specifically in the informatics savvy organization, which the core principles of which are listed here, which are being leveraged for this project along with all of the other TAP projects. I've heard about those. I'm just going to go over just the headings for those. It's all about collaborating. It's all about reusing what we can. We don't have to rebuild, enhance, but not just reuse what we've built, also what's already working in the informatics world. Enhance existing solutions and artifacts in a systematic way. Standardize, of course, develop everything based on standards. Sustain, develop the template policies and guidance framework to promote sustainability and interoperability, and capacity development to ensure availability of digital health capable workforce in the right places, the right numbers or the right skills. So I want to talk about the project roadmap that coming back from TAP, which provides us the basic background to specifically ours CARES Act funded project. We started, as I mentioned, early so April 2021 was when the funding became available, but just before that, because of the IPs were already working on the TAP, and they were going to leverage our TAP artifacts that we already had partially or draft developed. They had already been working on it. So you had a quick start on developing the rapid landscape assessment tool, conducted the landscape assessment, and at the same time, we started country engagement to some extent, to different countries. It was different extent depending on our engagement with the country for TAP. And then technical development, some of that because we're leveraging the TAP technical development, some of that you're seeing it started before September, but most of it is really going to be the part that's early on is just us preparing to launch, but really as the country engagement starts, we're working with the countries to identify exactly what the countries need, what their current needs are. As if you remember from yesterday's plenary session, a lot of work is already being done at the country level. And so we need to make sure that we are supporting the countries that we are providing support to, supporting where they need, because they've already started some work. So it has to be totally in alignment with that. And also from the funding that they have, if they have CARES Act funding or the ARPA funding, what funding they have, and we want to make sure that it aligns, everything aligns. And then the next is going to be in-country implementation. So that's going to come up later. And again, that's going to be driven by and informed by the country engagement. And our country engagement to start with is through the CDC country offices. And they, as you know, liaise and work very closely with the ministries and the relevant other health departments. So specifically about the landscape assessment that we're talking about today, and something about the design, the PEPFAR technical enhancement. Landscape assessment, the goal has been to identify COVID-19 related data and technical assistance needs for project countries and existing PEPFAR information systems and databases for potential expansion to support the clinical care, vaccine lab, and primarily the surveillance. It's at the end of the day, it's all about surveillance. Whatever information we get from clinical care, vaccine lab, it's all about to drive the surveillance. And we have 4 primary objectives for the landscape assessment, capabilities and needs of the existing COVID-19 landscape, identify opportunities to enhance PEPFAR HIS. So to learn where we are, what are the strengths, and where we can further build. Identify opportunities in the country HIS and to select countries and define specific technical enhancement projects. This is just another look at the same objectives, but how they relate to each other. Objective 1, 2, and 3 are parallel lanes because they don't really overlap much because they are clearly COVID-19 capabilities and needs. Opportunities to enhance PEPFAR capabilities, that's on its own. And then there is some overlap, but still at the same time, there is clear-cut distinction between them as well. And all 3 of those lead to objective 4. And at the same time, I think I should have put a block here, which is the country engagement. So as country engagements start, we'll share what we've learned through the objective 1, 2, and 3 deliberations that we've done. And then that's going to drive further country, even though we have initial selections, but we may be able to add further countries to that based on specific needs that are identified and technical projects that will be specified where exactly we need to provide support. Design principles, Manish is going to come back and talk more about it, but we do align closely with the TAP design principles and the standard information systems design principles across the world, which really is country commitment, leadership support, existing HIS infrastructure strengths. The end has to be interoperability. And where I want to end, and Manish is going to talk more about the design principles at the end of the other presentations. Where I want to end is the current pandemic is really an example. The idea is the bulk of the funding is available for PEPFAR implementation, but at the same time, the same patients, our PEPFAR patients, also have other diseases as they get into countries get into pandemics and other situations. The same patients are the ones who are dealing with and becoming several different victims of several other different public health conditions. And so we should be able to provide not just the PEPFAR care, we should be able to have a good handle on the routine care for future outbreaks and pandemics as well. And with that, I am going to escape out of my view and stop sharing and over to Manish for his section. Organizers, if you can unmute Manish, please.
Thank you. And thank you, Muzna. So let me quickly share. So Muzna has already mentioned about the objectives, the scope of the project. So I'll try not to repeat that. Hopefully you can see my slides here.
Yes.
Yes, thank you. So I'll quickly go through the methods that we followed. As you can see, it was primarily a desk review based on all the publicly available information, but that included informal, country level experience documents that were available and talking with technical assistance project. And you, as you can see, we have 3 different consortiums, and within that there is a large amount of expertise, people who work in different countries. So that was a good resource. But at the same time, we also want to acknowledge the limitation that, one, you may not be able to access all the available documents. Secondly, the COVID landscape is rapidly evolving. So it's possible what we did in the last 6 months, probably there's new information that is available. And when we review and gather or extract information and knowledge from these documents, it's based on reviewers' experience. So there can be a bias, or you can say it can be subjective from their perspective. Musna already talked about the three technical areas. So I'll not try to repeat this one. This one also you just heard in her presentation. We also talked about some of the sessions yesterday. This is how the TAP work is organized, these three pillars. And I'll also organize my presentation, the findings from the landscape along these three pillars. So policy and governance and effective information system are the two areas that are primary focused where the landscape findings came up. So you can see in the governance, the scope is to look at, how do we strengthen, standard-based health information exchange, but also countries' ability to national response on analytics and visualization, which allows a better decision-making. Similarly, on the information system side, how do we, strengthen implementation of OpenMRS, especially for COVID-19, or looking at the minimum data set that is needed, but also data repository with a central interoperability layer that allows exchange. So those are the key things within the scope of this project. What we found, and I would like to put a disclaimer here that this is not that applies to every single country. There is a wide variation. So in terms of strength, their dashboards are available both for PEPFAR and COVID, publicly available. You can download reports, statistics. There's facility level data available as well in many countries. And individual vaccination status information is also available. What is needed or where we see opportunities? There are multiple dashboards, so there's a need for integration, allowing clinicians to monitor the patients, especially those who HIV and also has COVID, allowing them access to the vaccination information is also an opportunity and a need, but also looking at patient identity matching when we have multiple systems being implemented in the country. So those are the area where there's a need and there's an opportunity for CARES Act. And that all depends on what is prioritized when we are in consultation with the countries, which is part of our country engagement plan. For effective information systems pillar, we'll say the strength, 4 of the countries that this project is being implemented are using OpenMRS, base EMR for HIV care. National data repository also exists in some of the countries. There is some interoperability when it comes to EMR exchanging data with HIS. Lab information systems are being used for COVID-19 lab results, and DHIS Transformers is also used for aggregated data visualization. And there are different funding streams that PEPFAR has through the CARES and ARPA that is being used here. While these are the strengths, we also see some opportunities and where is a need for technical assistance. Gap of data interlinkages, again, EMR and LIS, and national data repository interoperability work. EMR and DHIS interoperability in some countries in very early stages, so that's another area of an opportunity. And developing COVID-related OpenMRS package is another area for need. And you will hear from my colleagues more on that aspects, both on the data repository aspect, but also on the OpenMRS packages. This is a generic view of how the COVID-19 surveillance workflow works. So you can see on the left, when a patient comes in, go through the facility, test results, depending upon what results it is, positive, it goes up to the level where task force assigns, assesses options, and then looks into provision of care patient. But if it's negative, then it is updated through the channel, which is part of the national reporting as well. This is just an example of how, in Nigeria, different dashboards are organized, different reports are available publicly. People can go and access and download it. So this is, an example of how countries are currently prioritizing and working on. So I'll stop here and I'll hand it over to the next presenter.
Thanks, Manish. I don't see Veronica on. She was there earlier for some reason. Veronica, are you there? The organizers, if you can unmute Veronica Muti. In case you've logged on with a different name, Veronica.
I am online.
There you
Hello?
go, Veronica. Yes, we can hear you.
Okay, thank you. Let me put my slides on, please. Give me a second. I think Manish needs to stop sharing. Okay. Please let me know if you can see my slides.
We can see it.
Thank you.
Thanks.
So this is a build-up on the landscape assessment discussion that Muzna and Manish have already started. And for this discussion, I will be talking about the technical enhancement design for supporting COVID-19 surveillance and response. A number of questions are being asked by many regarding COVID-19 and HIV linkage. For example, are people living with HIV at a higher risk of more severe COVID-19 disease, a correlation between COVID-19 vaccine efficacy and HIV, COVID-19 disease progression in HIV patients, as well as dynamics of COVID-19 infection and HIV comorbidities. This is just some few questions, but there are many more questions with regard to COVID-19 and HIV linkage. The answer to these questions requires data that is timely and accurate. And when we think about the role of electronic systems, this is one of their key area that they could really support in. I think for most of us who were in the discussions that were in the conference day 1, day 2, and particularly yesterday's discussion or presentations, we heard that countries are, or other countries, some countries shared how they are customizing their systems, specifically EMR systems, to support COVID-19 data collection. For example, there was a case of Uganda EMR and Nigeria MRS. And I'm also aware, and also based on the landscape assessment, that Kenya EMR is also being customized to support COVID-19 data collection. It seems like some of these efforts may be duplicative in the sense that these three systems, when you think about it, they are all built on OpenMRS. So, and the question here is, could there have been a better way maybe to consolidate these efforts? Probably. On the positive note, PEFA has invested heavily on these OpenMRS solutions, and several of the top countries are actually using OpenMRS, like it has been alluded before. And the opportunity here, or these systems present an opportunity to support COVID-19 surveillance, data collection, analytics, as well as reports generation. So going back to the issue about duplicative efforts or duplicative systems or features or modules that different countries are working on. TAP mechanism is trying to address that same issue, and how it's doing that is by supporting the development of ORI. ORI stands for Open MRS HIV reference implementation. And it's good to mention that ORI or ORI artifacts does not imply a loss of existing investment or loss of local branding or loss of country ownership or readership. Basically, if I can just give the example of just the COVID module that I talked about, a country that is already using OpenMRS system can plug in a module or a package for COVID without necessarily having to lose every other feature or anything else that they have built within the system. So they can just pick the COVID module to support the data collection for that and analytics and reporting. Again, building up a little bit on what ORI is, it's built on OpenMRS 3.0 platform. Its foundation represents best practices with regard to its design and technology approaches, like the use of improved user experience, micro fronted and standards. ORI, though currently is being focused on HIV and COVID-19, it's extendable to other programmatic or program areas. And I would like to highlight number of features for ORI COVID, and that includes case assessment, lab test outcome and vaccination data correction, case reports generation, as well as general reports generation. And the ORI team is also exploring the HIV COVID linkage, and also working on, we'll be working on interoperability between the clinical and the lab systems. So this is a mock-up or just a screenshot of the COVID-19 homepage. And basically, you're able to see a number of tabs here, and these tabs can actually be, I mean, if more are needed, they can also be added here depending on the needs or the interests by the providers, healthcare providers. So for now, what we have is all COVID clients. So the system will be able to give a list of all the clients who are COVID-19 and who have COVID-19 infection, pending, those who are pending lab results, undocumented outcomes, partial vaccination, and many more. So this is still work in progress. So in this screenshot, we have two of them. So on my right, it's basically the COVID-19 patient page. And on the right is sample or lab test form that is built within ORI to support the data correction on the lab test and results. Last but not least, we have also developed a full standard-based concept dictionary for COVID-19, and that could be used by other organizations or those who are working on their development for COVID packages. And if you can see the number of concepts, you're able to see that we have majority of CL concepts, but we also have a number of custom concepts that we couldn't find in CL. Thank you very much. That's the end of my presentation. I'm going to give it back to Manish. Thank you.
Thank you so much, Veronica. Next is Daniel Futterman from Jambi. Organize. I think he's already a co-host.
I'm just going to share my screen quick.
Thanks.
So hopefully that's popping up with the presentation view.
Yes, we can see your screen. Thanks.
Perfect, thanks. So I'm going to talk on behalf of sort of the Jambi Consortium and what our role has been on the CARES Act project and within the landscape assessment objective. So the Jambi Consortium has included the UCT CIDA, Center for Infectious Disease, Epidemiology and Research, and they've supported us on some of these landscape assessment work. So as was mentioned earlier, Jambi's role has really been to look at the dicey objectives, so the data integration strategies and implementation objectives. And this is really all around the sort of central data exchange and interoperability areas. So that's your data exchange with point of service systems, with your lab information systems, supporting sort of soft skills and improved data governance, as well as some specific areas of making sure that there is patient identification and matching in place to uniquely identify patients across systems and within a country, as well as supporting a central data repository that can actually be used to support that surveillance at a central level, and be able to generate sort of visualizations and then support custom analytics for that. So within the scope of the landscape assessment, the DICE objectives have really been to better understand either existing or planned measures within countries of COVID-19 monitoring surveillance activities, to look at the strengths of existing PEPFAR HIS that could be leveraged to support COVID-19 surveillance, and any digital technologies that are being used to either collect, manage, or analyze COVID-19 surveillance data, as well as looking at the strengths or sort of needs of current or planned approaches within that. So what we've found within that DICE-specific working area within the landscape assessment is there were some sort of general findings that I'm going to just step through. So the diagram here is just an example of a data flow of a surveillance platform. This is from the Ethiopia example, but really what we found is looking at countries that there seem to be some common sort of areas or common functionality that had been implemented within COVID-19 surveillance. So what our findings suggest is that there definitely is some level of collation of COVID-19 data, either at central or national levels. That collated data is usually aggregated, but with some level of disaggregation, usually by sort of region or administrative areas. There is some evidence, although our findings suggest that there is sort of some lack of the interlink of data between COVID-19 and HIV surveillance systems, and that patient identity matching is supported in some regards, but that there is sort of areas for improvement of providing that identity matching across COVID-19 systems. And then finally, one of the findings was that there definitely is evidence of data exchange, of centralization and collation of data, but our findings suggest that there maybe is room for improvement in terms of standards-based data exchange and interoperability, as well as sort of building capabilities around that. In terms of the lab information systems, again, just focusing specifically on this aspect, there's definitely evidence of COVID-19 testing being captured digitally in your lab information systems. And we did find that there is evidence of centralization of that lab data, although in some cases that lab data is being linked with your sort of patient records and at your central levels. But in some areas, there is sort of potential for better linkage of that lab data with your data at a central level and with your aggregate data. So here is it's just an example diagram illustrating a data flow, and I think the key thing here is just pointing out there was a similar diagram shown earlier, that there are some common sort of entry points and some common data collection sources across the board. So although countries may be using specific systems or have some unique sort of points of entry or particular flows, there definitely are some common themes here in terms of capturing data around suspected COVID-19 cases or doing COVID-19 screening, using that data as part of a case management workflow, and centralizing that data for the purpose of then aggregating or analyzing that data. As well as integration of your lab system workflows of either sort of issuing lab requests and bringing that testing data back into the point of service systems or to your central system to be able to improve, sort of get better analytics out of that central system. So the potential opportunities that we see here in terms of the DICE objective, there has been some design of some generic architectures based on a lot of what's been done in the CDC TAP projects. But what we're seeing is the potential for sort of building generic architectures that could be adapted for country needs. And those architectures really are just supporting some common sort of technical pieces within that, not being necessarily application specific, but a general sort of principles around that. So there's definitely the main sort of opportunity that we see is to leverage existing PEPFAR investments in HIV systems for both patient and case management, and applying that or leveraging that for COVID-19, as well as for laboratory testing and results management. Secondly is to either extend or adapt the HIV case surveillance systems to support COVID-19 surveillance, adding support for things like patient identity management to address any of those COVID-19 specific data exchange use cases, and then improving collation and centralization of that COVID-19 data for better analysis and reporting at central levels. We touched on the lab systems and definitely see an opportunity to support lab system interoperability and data interfaces to incorporate that lab data into your central data repositories. And finally, there's definitely an opportunity to not necessarily reinvent the wheel here, but to leverage and adapt existing tools and artifacts and solutions for COVID-19 data exchange. So looking at what other communities or what countries are already using for these things, and trying to sort of build on those to improve this. So I'll pause there and just hand back to Musna. Thank you.
Thanks so much, Danielle and Manish and Veronica. So I don't see a question written so far. Floor is, how many minutes do we have, Priscilla? Or any other co-host?
3 minutes, please.
Okay, thank you. So I don't see any other question. If you can unmute Manish, and you can, Manish, if you can go back to, while people are typing thank you. While people are typing some of the questions, we can go ahead with just a review of the dashboard design principles. In fact, my correction from me. So earlier what I had shown was really the design principles for the entire project. What Manish is talking about is dashboard specific design principles. So go ahead, Manish, and others, please type questions now. Thanks. Manish, we can't hear you yet.
Thank you. Yeah, I was just waiting for being on. So as Musna mentioned, these are some of the design principles, and we heard from my colleague Veronica and Daniel, both on the Panama's package or I package, what we call, and the data integration work stream. How are we going to support the analytics and visualization part? That is part of the overall health information to work. So some of the principles that Musna mentioned earlier about our project are also influencing what we have here. Looking at what PEPFAR has already invested, the investment of systems that are already there, and looking from a perspective that how it allows immediate access to the data. That's one of the key things. It seems
the
like
screen share changed.
It's showing me the timer. I'll finish before that, I can guarantee that. Yeah, well, thank you. So providing immediate and easy access to better data, that's one of the key principles. And then making sure that who is the decision maker is something that is influencing the design of the visualization. And we mentioned one opportunity for integrated dashboard. Again, that is very much around users, the different decision makers, and depending on how easy access to data is needed. And that tells us that it's better to put it in one place. But doing all that while making sure that we are using standardized approaches and framework and not creating something that cannot be replicated in other places. Those are the design principles that we have for analytics and visualization. And here are some example recommendations. This is one from WHO on ARV disruption due to COVID. There is another example is coming from UNICEF that looks at HIV estimates for children dashboard. So there's a very nice interactive dashboard that UNICEF has for different data sets and different decision makers. So those are the key things from the principles, but also a few examples that others have done. These are references here. Muzna.
Thank you so much, Manish. Let's leave this. Thank you. Slide up. So I have not yet seen any question. So maybe people are exhausted. It's been for those of us who were attending this overnight. It's been quite long days, long nights, and so I have a question for some people, and I've added that in the chat as well. So other than our project countries that we've already talked about and those who presented yesterday, Uganda, Ethiopia, Haiti, and Nigeria, and Kenya we're already working with. Does someone attending from another country have something to share with us, work you're doing that aligns with ours? If there's something, we may not have time to go into details, but if you have work that aligns with us, if you could type your name and contact information, please let us know. I'd be happy to talk to you later on to learn from what you're doing and to see how we can further improve the wheel that we're building.
Thank you very much, Mushna, and the rest of the panelists for that very, very, very nice discussion. I want to hand over to the president of the Uganda Health Informatics Association to give a few remarks, and after I invite the chairman of the Helena board. Thank you.
Thank you very much, our MC of the day, Madame Joan Nachibuka. Now may thank all the participants who have taken part in this conference for the 3 days. We thank you so much. I believe all of us have learned a lot from the presentations, from the speakers, and the panels that we have had. Without further ado, let me welcome Mr. Tom Oluch to give the closing remarks for the conference. Tom, over to you.
Okay. Yeah, thank you very much. Thanks. I can't believe it that we're already at the end of the conference. It's been an eventful 3 days, a lot of learning, and just a lot going on over the last 3 days. So yeah, again, all protocols observed. I just want to start by first thanking the local organizing committee under the chairmanship of Carol, and then all the colleagues that worked closely with her. It's been a great 3 days that we've really enjoyed and listened to a lot of things. The workshops were amazing. I mean, we talked about practical applications of various tools and models, including capability maturity models, health information systems management tools, other digital systems assessment tools, and so on. But also around the workshops, we also talked about cost evaluations, which I think is a very, very important component of what we do. In digital health, we need to be sure that we know the cost of what we are implementing and the cost of sustaining them, especially if you think about long-term sustainability. So that cost component, I think, was very exciting. But we also heard about other exciting things during the presentations over the last 3 days about advances in digital technologies and application and reuse, including like some systems that were originally developed for HIV support, but they're now being used for COVID response, lab systems, DHIS2 used as a repository and an analytic tool in COVID-19 response. So all very exciting stuff. We heard about EMRs and community-based health information systems. And of course, they have a big role to play in universal health coverage goals and immunization and so on. And then, of course, leveraging digital health tools for education and supply chain management in public health emergencies. We had about e-health architectures and also had a lot about health information exchange, starting with the high-level presentation we had from Africa CDC, which was amazing, just developing the policies and guidelines and standards for health information exchange in Africa. So we are really grateful that Africa CDC were able to find time to give both the keynote presentation, but also had a panel session earlier today. So we're very thankful to them. So yeah, it's been a great, and I'm sure many of you have enjoyed yourselves just as much as I've done. And again, looking forward to the next Helena conference. As Carol, the UGHIA president, said at the beginning of the conference, it will have been really nice. And I think Dr. Evelyn also said the same. It will have been really nice to see you all in person. But unfortunately, being where we are, we had to hold this conference virtually. But we really hope that in sometime next year or so, when things are more, vaccination coverage is better and infection rates have come down, that we can get an opportunity to share in person. Yeah, and just to get to network better, to meet each other, know each other, and also just share best practice and experience. So I'm really excited to have presided over this this Helena conference. And again, I just can't thank enough the local organizing committee that worked with the Helena board, Carol, Jonathan Pango, Priscilla, Haron, and Oz, and you guys are all amazing. I mean, it's been really great working with you. And also, like I said yesterday, this is my last Helena conference as the president. So I'll be stepping down, and the president-elect, Francis Baba, will be taking over starting November this year. So it's actually starting next month. So it's been amazing. And just before I finish, I was just going to ask for a minute or two of your time to just share with you real quick the Helena website, which we talked about yesterday. We just didn't get an opportunity to share it, but we'll just take 1 or 2 minutes to just show you what it is. And as Steve said yesterday, this is like an opportunity to get people to give us feedback on the website, and we're going to be improving it with time. So Steve, I don't know if you're ready to just have a minute or two to just quickly flash through the website. And the host, if you can please unmute Steve Wanye, just share with us real quick.
Thanks a lot, Tom. So I'm just going to show this really quickly, the website. Let me see if I can get to it really quickly. Just give me 1 second. Please let me know if you can see, excuse me, if you can see the website. So this is a new Helena website. So you can also access it on helena.africa. So as our president, Tom has mentioned, this is part of the infrastructural upgrade that the board is working on. It's been work in progress, and it's not complete, but we thought that we could do a soft launch, just share where we are right now and really seek for your input. So when you get to the website, as you'll see, the couple of menus, as you'd expect, the typical menu items, just walk through it. There's information about who Helena is, how Helena works, through the working groups. Of course, the most prominent working group that has been featured over time is the education working group, but there are several other working groups, not as active, but again, we encourage everyone who has specific interest in these subjects to step up. And as was mentioned yesterday, anybody can become the chair of the working group. Just really requires level of capacity, but more importantly, really passion and the ability to work with others to drive certain agenda. So there's a standard interoperability working group, policy and governance, data mining working group. There's one on Helena nursing special interest, and we can create others depending on the interest we get from the members. There's an item there on country membership. You can get to see which countries have national associations. Some may not be as active as others and all, but these are the countries that have actually gone ahead and created their own country level associations. You'll find information about leadership and governance. And as Tom mentioned, his term and my term as well comes to an end. So there'll be elections held and information will be shared. So again, if you're interested in supporting and contributing Helena in terms of leadership, please step up, put your hand up when the elections are called. For those who've been part of the past conferences, you can go to the conferences menu and you'll find information about the last couple of conferences. There are lots of really nice, beautiful pictures there as well. A lot of information about those conferences, what was discussed, presentations that were made. So there's a really huge repository there. That's a wealth of knowledge. There are a couple of other items like Helena events that is still under construction, but here is where you'll see in a calendar format what Helena is planning, and you can then pull that directly to your personal calendar for purposes of scheduling and planning. There's an item there for news and publications. Again, the Journal of Health Informatics in Africa has been mentioned several times, where a lot of the presentation will be published, of course, with the consent of the authors. And the idea, again, just because this is part of Helena's core mission, is to ensure that we create a repository of evidence for health informatics and digital health in Africa. And yeah, most importantly, please contact us. There's a contact us page there. Get in touch with us. As been mentioned before, the conferences are really limited opportunities for us to interact, but in between conferences, there are many ways that we can interact. As you notice also when you go at the top of the website, can't see that very clearly from where I am right now, but you'll probably see there's some links that take you to the Education Working Group website. So over time, that will be rolled over and all of it will come under this one website. So there'll only be one domain name, helena.africa. But you also want to make sure that there's as minimal interaction as possible to what has been done by other arms of Helena, including the working groups and another that has been done in the past. So that is all seamlessly available in one place. So please visit the website. You can click on this balloon here and share with us your comment, what you think about this new website, what we can do to improve it. And most importantly, please get in touch with us through the contact us form. Let us know who you are, where you're contacting us from, and how you'd like to get involved in Helena. Thanks a lot, and back to you, Tom.
Thanks a lot, Steve. That was quick, but very, very informative. So please, and yesterday during the Helena presentation, we showed you ways by which you can get in touch with Helena. You've seen the website. You can get connected through working groups, through your national society, or just come directly to us and we'll direct you to the right place to go. So with that, again, I just want to thank all the presenters, all those who submitted abstracts. They were amazing abstracts. I think we've had very good presentations over the last 3 days, and I just want to commend all the presenters. And again, just one more time to thank the LOC under the leadership of Carol for the great work. And we really look forward to seeing you again during the next conference. So with that, we come to the end, and let me hand it back to Carol. Thanks.
Thank you very much, Tom, for the closing remarks, and everyone for the active participation. We are going to be awarding certificates, but this will be sent to individual email addresses. We have all the email addresses for the participants, but also we request that all of you enable your videos briefly before we go, so that we can capture a picture, not physical picture, but an e-picture of all of us who attended the conference for our records. Briefly before we go, can we all enable our videos? Thank you.
So, hi from us, the command center. Hi.
But you know you're not saying.
Hello? This is us from the command center.
Kindly enable your video. Okay, thank you very much.
Spring screen.
Elizabeth, Sharon, Kimberly, Obo, Monica, kindly enable your videos and wave to the right. Thank you so much, everyone. Enjoy the rest of the day, and we wish you all the best. We'll be sharing the presentations on our website. Thank you very much.
Thank you. Bye.
Thank you.